last time we went through monomorphic ventricular tachycardia. I'm going to go through polymorphic ventricular tachycardia and treatments. They are different in terms of treatment. That's why I want to go over. And if you give the wrong treatment, there's a high potential of causing essentially death to your patient or serious injury, right? So this, as you guys can see, this is a polymorphic ventricular tachycardia. By the way, what's the difference between monomorphic and polymorphic?
The morphology for monomorphic would all look the same.
Excellent.
And polymorphic is all different.
All different, right? So, so excellent, right? So monomorphic, same morphology, mono, poly means many, right? Here, this is a particular type. This is Torsades de Pointes. This is twisting of the points. So it's a particular polymorphic, but there's many others, right? And what causes it is usually prolonged QT interval, right? Interval is prolonged, and what you see is this was a normal rhythm, right? And then what happens, there is a ectopic beat that lands on the downsloping of the T wave, and then it sends dispersion into torsades, right? And they call these rhythms, the torsades particular, they call it paroxysmal. Paroxysmal ventricular tachycardia. What is a paroxysmal? Sudden onset, right? And it terminates. It may start on its own, right, with ectopic beat. It will go for maybe 90 seconds, and it will terminate on its own, right? Sometimes in sometimes they break down the rhythms into these categories, right? I'm just going to write this down so you're familiar, right? So normal heart rate is about 60 to 100, right? So 60 to 100. You guys can see, you can pivot. All right, so 60 to 100. So anytime you get to 150, so here you have your basic tachycardias. All right, so 100 to 150 your basic tachycardias. Once you get to this level, right, 150 to 250, this is where you get those paroxysmal tachydysrhythmias, right? And then at 250 to 350, right, at this point here, this is where you get flutters. And then above 350, so I'm going to say above 350, this is your fibrillation. And obviously below 60, this is your bradycardias. So the reason why I bring this up is that when we're dealing like with ventricular tachycardia or true, right, torsades, you're dealing in this range, right? Usually greater than 150, but truly speaking, probably above 200. So 200 to 250, you're dealing with paroxysmal rhythms. They come and go. Above that, you're dealing with flutters. Above that, you're dealing with fibrillations, right? So, and right. So here's an example of this. Here's a 12 lead they did, and sometimes you guys may be confused, right? You look at lead 2, and some of you call this V-fib, right? Because you're not sure. But can you have someone with V-fib as a pulse and talking to you? No. No, right? So if that is occurring and the guy's talking to you and you're seeing this on the rhythm, chances are it's not V-fib. So do a 12 lead if you're not sure. And when you do a 12 lead, you see these precordial leads, right? What does this look like? Right? So you could see the twisting of the point. So this is a clear-cut polymorphic ventricular tachycardia, right? So if you're not sure the person is talking to you, the 12 lead right here, you cannot see it, but you know what I notice? I notice there's a prolonged QT interval, right? And there is some ectopic beats that are landing on the vulnerable period, like RNT, right? So like this one here. So this is what they call RNT phenomenon, right? So then we have our New York City REMAC protocols, right? So let me ask you this question. You have a guy who presented with this paroxysmal rhythm, right? You weren't sure, right? You did a 12 lead, let's say, and then you say, okay, I think it's torsades, right? And then you open up your protocol and you say, all right, I'm going to give him treatments. First, you have to determine if he's stable or unstable. Let's say he's anal times 3, blood pressure 120/80, heart rate is this, respiratory rate, let's say, is 20, saturation is 95, right? So stable or unstable? Stable. Okay. What are we going to do? So somebody raise their hand, say.
I'm going to call for the magnesium drip.
Magnesium drip. All right. Anyone here like to give the standing orders before you call medical control? We have standing orders, stable. We have option A, amiodarone, and we have a lidocaine, option B.
I don't think so.
Okay. One person says, I don't think so. Who would like to give standing orders initially?
I would give standing orders.
You give standing orders.
Yeah.
3 people.
No.
And no. Why not?
Because Torsades has prolonged QT and magnesium shortens QT. The rest would probably not help with that.
The rest would not help with that? So are you saying we are not to give our standing orders?
Maybe.
Telemetri's gonna ask you if you did your standing orders.
Yeah, so you're saying we have to give it, right? So we don't know, right? So do we give the standing orders or we do not give the standing orders, right? So that's the confusion, right? And this is why it's very important I bring this up, is because when I was testing, right, and we were doing the scenario, some of you gave the standing orders, some of you did not give the standing orders, and so what's the confusion here? The major issue here is this: if you give the standing orders, you may kill your person, and I'll explain to you why. So if you follow your standing orders and you give these medications, especially lidocaine, especially amiodarone, not lidocaine, especially amiodarone plus 3 medication, you can kill your person, your patient. So I'll explain to you why, right? So what is Torsades, as we said, right? It's a twisting of the points, the polymorphic V-Tach. Usually the ventricular rate is greater than 200, as we just explained to you, right? It shifts about the baseline, that's why they call it twisting of the points. It has paroxysm of less than 90 seconds, so it comes and goes, right? And what you see is, it's usually in a setting of prolonged QT interval, right? And what you notice, it's very often seen in women. You also see this in alcoholics. You see someone who has, right, congenital problems, or they call it, right, acquired. So acquired Torsades, usually medications will cause it, different medications, different electrolyte abnormalities can cause it. So we'll go through all of this, right, that causes this type of dysrhythmia. So very common, right, prolonged QT interval. And here the very common causes is electrolyte abnormality, right? So hypomagnesemia, that's why we were talking about giving MAG, right? Hypokalemia. And then these medications here, right? Class 1A, Class 1C, right, medications. And then Class 3 medications, which I'm going to show you what they are. So very important. Class 1A and Class 1C, why they do that? Because they prolong the QT interval. Class 3 will also prolong the QT interval. And then if you have a combination of those drugs, they'll definitely prolong the QT interval, right? So here they show you, right, the major causes that are acquired. This is the ones we're worried about. Congenital, I'm not so worried about. There are few, right? And usually they're treated differently than these. So your regular acquired ones are usually medication-induced. So Class 1A, Class 1C. There's sodium channel blockers. And then you have electrolyte problems, hypokalemia, hypomagnesemia. Rarely is low calcium. Could be diet-related. Starvation, low protein, right? So if you have an alcoholic who is consuming alcohol, he's not eating, right? He may have low protein, his diet is not on point, and he may have electrolyte problems, or she, right? Severe bradycardia or atrioventricular block. In this setting, right, you basically have very slow heart rate, prolongs your QT interval, right? And a few other conditions. But the main ones we worried about are these ones here. So the drugs, Class 1 is sodium channel blockers. So you see Class 1A, they give you medications like percatamide. We're not really giving this. Lidocaine is Class 1B, right? So lidocaine doesn't really prolong the QT interval, but it's not going to help your patient in the setting of Torsades. So you're not really prolonging the QT, but you're not helping them either, right? Class 1C, flecainide medications. Again, you don't carry these medications. And then the other medications that we do carry, right, is Class 3. It's amiodarone, and the other one that prolongs the QT interval quite often is sotalol. So amiodarone, right? So this medicine will make your QT interval longer. So what do you think will happen? You got a patient who has Torsades, and then you follow standing order. You infuse 150 milligrams in 100 ml, right, over 10 minutes. What do you think is going to happen?
Cardiac arrest.
Cardiac arrest. Okay. Guy goes into cardiac arrest, maybe VFib. You start doing your standing orders. What do you have in your standing orders for VFib arrest? More amiodarone. More amiodarone, right? Or more lidocaine, right? Again, the drugs that don't help you and kill the person even further, right? Just to make sure we didn't kill him the first time with 150, we're going to give him 300 to confirm the death, right? Right? And a lot of cases we've been doing is like, I show you the Torsades. You guys say, all right, I'm going to give 150, right? Of amio. Guy goes into VFib. You guys start running your arrest, and you're like, all right, epi, amio, and confirm death, right? So this is a good book I told you to buy, right? And if you look up your medications, they list your favorite drug, right? Amiodarone, and they say here the precaution, right? It says it prolongs the QT interval, and you will not administer with any other drugs that prolong the QT interval. Yeah.
Oh, that's American.
this book has all the algorithms for PALS, ACLS, BLS, all the drugs, right? If you get a digital version, you get a free farm book, so you get all the drugs and indications, contraindications. Right? They're not going to be the same doses as your REMAC protocols, but they will list out, you know, everything you need to know. So if you know this, you're in a good shape. Right? So some of the side effects of amio, right? Remember I told you, right, it causes hypotension, so that's why we don't want to give it fast, right? It slows up the heart rate, right? Decreases contractility, and it definitely prolongs the QT interval. That's why we're worried about this. So any antiarrhythmics do not infuse fast. This is what's going to happen, right? Right, and there was some AHA studies, so they looked at, you know, what the problems are with Torsades, right? So they said they looked at the QT interval, right? What's an abnormal QTC interval? So QTC stands for the corrected heart rate, and they said any interval that's greater than 500 milliseconds is considered high. They do have some numbers for males and females, right? They'll say about 470 milliseconds greater for males and 480 greater for females. But if you remember 500, it's a good even number. So if your QTC is greater than 500, you are dealing, 500 greater I should say, you're dealing with a prolonged QT interval. Where would I get this number? At the top of the strip of what? Of a 12 lead. Of a 12 lead. The 3 lead will not give you that, right? So I need to get the 12 lead if I want to get my QTC interval. You could calculate it if you want. I'll show you how to calculate it. I don't calculate it. The way I do it is I'll do a 12 lead, but I'll show you how to calculate it if you guys want to see it. The other medications that cause prolonged QTC interval is very common as tricyclic antidepressants, right? You have certain antibiotics, right? And then you have Sotalol is class 3, and then they say amiodarone associated with QTC prolongations, right? They say reasons poorly understood, but it's an antiarrhythmic and definitely prolongs the QTC interval. Yeah, Zofran does it too. Zofran does it too. That's why they say you want to do a 12 lead to make sure you don't have a prolonged QTC interval.
So if we have an alcoholic vomiting who has Torsades, you don't want to give
Zofran. Yes, you don't want to give Zofran for those patients. Absolutely, right? So here,
I have a question. The 500 milliseconds, is that the same as 0.5 seconds, 500 milliseconds?
Yeah. I'll show you how to calculate it once we'll give you an example so you guys see it. But I personally don't calculate it. Here they give you all the examples, right, of the risk factors. So they say QTC interval corrected for the heart rate is greater than 500 milliseconds. They will say the other problems, right, prolonging drugs, right, antibiotics, tricyclics, right, antiarrhythmics, especially 1A, 1C, class 3, in certain heart disease, female sex, and then electrolyte abnormality, right? Most likely hypokalemia, hypomagnesemia, hypocalcemia not so much, diuretics because they also adjust your electrolyte, right? So you may have imbalance there. Bradycardias because your heart rate gets slower, so your QT interval becomes longer, right? So those are the risk factors. So here they say the definition here for what's considered prolonged, right? They say it's basically 500. And here they use the 99 percentile, and they say 470 milliseconds for males and 480 milliseconds for females. If it's greater than that, it's prolonged. I will say, remember, if you want to remember one number, remember 500, right? You can't go wrong with that, right? This guy, right, Mr. Henry Bazette, he put a formula, how to calculate it. I'll show you. I don't really do this in the field, but so you guys understand how this works. So here he would have a rhythm, right? He will have a rhythm, and what he does is he says the formula for corrected heart rate, because, you know, we cannot say normal QTC is 44 seconds, 0.44 seconds. We can't say that because it depends on the heart rate, right? So it has to be corrected for the heart rate. So what he does is he looks at R to R interval, and he basically counts the number of small boxes. And here, the amount of small boxes is 24.5. He multiplies it by 0.4, and there's 0.4 seconds in every small box, and that comes out to 0.98 seconds. And then he looks at your QT interval, right? So if you remember from your EKGs, right, your waves. So this would be the P wave, right? This would be the first down sloping is the Q. The positive is R, this is S, and this is T. So they look from the Q to the T wave, and they count this distance there, right? So you can see exactly what they did. You have the downsloping Q up until T, right? And they say it's 13 small boxes times 0.4 seconds. This is 0.52 seconds, and the formula being the corrected QTC interval is the QT, right, which is 0.52 seconds, divided by square root of 0.98 seconds, which is R2R interval. And here they got 0.525, which is they rounded to 0.53, which is definitely above, right, 0.5, right? So your question was 500 milliseconds, that will be 0.5 seconds. So we can definitely see it's prolonged. Are you going to do this? Probably not. I mean, you know, you guys want to, you know, do it efficiently. And I can tell you the algorithms that these machines have when you do a 12 lead, it's much more robust, much more efficient. And I also would like to have a 12 lead, right? So I kill two birds with, you know, one stone. I get the 12 lead plus I get the numbers, right? So what I do is I do this, right? I do this and then I look right here. So it says 512 milliseconds. Is it normal or prolonged? Prolonged, right? So this, so keep in your head, the longer the the QT interval, the higher the likelihood of them going to Torsades if there's an ectopic that falls here. Any questions so far? Clear? Right? In the same book that I showed you, right, the AHA book, they give you the numbers. So if you don't want to do the 12 lead, you could look, right, for the heart rate. So you look at the heart rate that you have, roughly 60, 62, whatever it may be, and then you go to the right and you see, right, the time increments, and here what's important, the limits for males and females. So if you want to download this book, it will give you this. Again, as I said, I personally do the 12 lead, and I look at the numbers here, but you could have it for the correct heart rate if you like, right? So here, just to show you, there's another EKG here. This is sinus bradycardia. It shows QT, prolonged QT, with bigeminy pattern, right? And this person, very important, they have low potassium, and they'll have low magnesium. So you see here, right? These are your P, QRS, right? And then you have some beads that are falling here, right? And this can cause this ectopy, right? R1T. So what happens here, right? In this phase, when you have a prolonged QT interval, this was your normal depolarization cycle. And when you have this abnormal phase, you have this prolonged because your phase now becomes longer. So if I draw this on the side for you. Yeah.
Okay, so, like a bundle branch block, right?
Not necessarily. So bundle branch block, there's another problem. The bundle branches in the heart that supply, right, I would say automaticity to the heart itself. There's a cutoff point. So that does not really have anything to do with the QTC interval per se, right? What the problem in this setting, I'll show you. So let me put this up so you guys can see, and then if you're still not sure, you can ask a question. So first I'm going to draw the normal one, right? And I'm going to draw the prolonged phase. Right, and we said this signifies your QRS depolarization, and this is your repolarization, right? This is your ECG here, and here we're going to do it. Right, so you can see right here, it's longer, right? And if you remember from when I was showing you guys the channels and all this, right? You remember, right? Initially we had sodium that came in, and when it went to, let's say, negative 70 millivolts, it opened, right, the sodium channels. And then sodium from the outside on the voltage gated channels came in, you had this upstroke, right? And over here, what happened, we had potassium channels that was open, they were leaving. Right, potassium was leaving, and calcium was coming in. Through the same channels. And this would cause this plateau. Everybody see that? after a while, this calcium channels close, there's more potassium efflux, and this goes down. Make sense? But now look here, right? So we have, again, these calcium channels here. Calcium is coming in, and we have potassium that's leaving. But because of this prolonged period, right, there's more calcium that's now inflowing. You guys see this? There's a longer period as opposed to here, right? So what this does is, because you have a longer period, if you have an impulse that can come in, it can cause RNT phenomenon and cause it to go into polymorphic V-Tach or maybe other type of V-Tach, right? And so we have to somehow treat it, because this, they call it early after depolarization. Sorry, early after depolarization effect. And what we have to do is we have to somehow stop this entrance of calcium. The moment I stop this entry of calcium, it makes sense. The moment I stop flow of calcium, I'm going to shorten this phase, because the only purpose this plateau is going on is I have positive charges leaving and positive charges coming in, and they equalize each other. But the moment I close these channels, you have more potassium leaving. So this will then regain this. Make sense? Right? So if I block this, there's no more positive coming in, but K is leaving. This K is leaving is going to make it more electronegative. So what drug do you think will block my calcium channel?
Tiresome?
Calcium channel blocker? So in this setting, we give magnesium. Is that right? So why do we give magnesium? Right? So we said, in a lot of you said, right, we give mag sulfate as the treatment for this condition. Right? So I'll show you why.